Good afternoon, everyone. My topic is about cystic lesions categories in lung cancer screening and inter-reader variability evaluation. It has three parts: the importance of cystic lesions in lung cancer screening, and the lung RAS classification for those cystic lesions. The third part is how do we evaluate the inter-reader variability and the survey result. There, in the 2012 I-ELCAP study, 26 of 706 screen detected lung cancers were found to abut or arise within the wall of a cystic airspace. And another study in 2021 found that among 441 patients diagnosed with primary lung cancer, 9.3% had cystic components on initial CT imaging. In a Nelson analysis, 22 of missed cancers at initial screening were associated with cystic spaces. So it's important to recognize the cystic lung cancer appearance. And there are 5 types for lung RAS classification for those cystic lesions. The type 1 is thin wall cyst. It's a unilocular cyst with uniform wall thickness less than 2 mm. Care should be taken to avoid mistaking vessels with nodules or wall thickening in the A3 images. Type B is a thick wall cyst. They are unilocular cysts with uniform wall thickness or asymmetric wall thickening or nodular wall thickening larger than or equal to 2 mm, but the cystic component is the dominant feature. It takes 3 months follow-up or PET-CT if the solid component is larger than 8 mm. Type 3 is a multilocular cyst. They are thick or thin-walled cysts with internal septations, managed as a atypical pulmonary cyst. It has the same recommendation as type B. Multilocular cysts are heterogeneous in appearance, contain internal septations, or may have solid or ground components such as thick walls, nodules, or internal ossifications. Type B is a cavitary nodule. The wall thickening is the dominant feature, managed as a solid nodule. This is an I-ELCAP case. Based on the size, it takes 6 months follow-up for the lung RAS recommendation. Type E is the cyst with the associated nodule. The definition is any cyst with an adjacent internal or external nodule. It could be solid or part-solid or ground glass. The management is based on the most concerning feature. Look at this nodule. It's a right middle lobe multilocular cyst with internal septations, but the internal solid nodule is 70 mm, so that the PET-CT or tissue sampling is recommended based on the clinical evaluation. The purpose of this survey is to evaluate the inter-reader variability for those 5 types of cystic lesions based on lung RAS recommendation. First, we're selecting 25 I-ELCAP cases, 5 cases for each type, and inviting 20 radiologists around the world to finish the survey online. Here is the list for different countries. They work on teaching file system. There is a cystic lesion survey here on the left side. On the top, there are the descriptions for those 5 types of cystic lesions and the confidence level of your decision about your every case. The numbers 1 to 3 represent not confident, moderately confident, or very confident, respectively. For each case, there is a short video on the top for each case, and there are 5 two questions and on the bottom about the TAP selection or confidence level. This is the analysis results. In these colorful images, the x-axis represents the cases. There are 25 cases here, 5 cases for each TAP. The 25 cases were present to the 20 radiologists in random order. The truth is the consensus of 2 independent radiologists. The y-axis represents the number of radiologists. Interestingly, there are only 2 cases with complete agreement across all readers. They are case 70 and case 22. And there are 4 cases. There are 4 cases reported by 4. The table 1 showing the distribution of the numbers of TAPs assigned per cases. There are 4 cases reported by 4 different TAPs in moderate or high confidence level. There are cases 5, 7, 15, and cases 25. Table 2 is showing the agreement by truth TAP between the 20 radiologists. The lowest one is type A, unilocular thin wall cyst. It's 57%. Here is a case with a different opinion. It's a right middle lobe unilocular cyst with nodular thick wall thickening measuring 3 mm on the bottom. The truth is type B, unilocular thick wall. It takes 3 months follow-up based on LANRAS recommendation. But one radiologist selected as type A, unilocular thin wall. It takes 12 months follow-up. Other 2 radiologists selected type E, any cyst with associated LAN nodule. It takes 3 months follow-up and changed the follow-up time. Does it matter if we report it as a different TAP for workup recommendation? In this set of 25 cases, the radiologist reported that a different TAP would have led to 22 earlier follow-up and 9.8% delayed follow-up on average. Thank you.